Welcome to the AA Podcast, our little corner of the web where we are not afraid to discuss tough questions like,
when did nutrition, health, movement, and stress management become alternative medicine?
Where we embrace challenges in all aspects of life to become healthier and stronger versions of ourselves.
And where food and movement are the best kinds of medicine, and cooking meals at home is a revolutionary act. Hello, and welcome back to another episode of the AA Podcast. This is Ashley Olson.
And I'm Andrea Crane, and Andrea Crane's big hair.
Yes, you can't see her hair, but she
God,
got on, and I was like, "Oh man, we got some lion mane."
It won't even fit on the camera. It needs its own headphone.
Yeah. She was trying to put her headphone on and she couldn't even pull it on. It was so
Oh
big.
my gosh. Yeah.
It's fine,
Okay.
everybody.
Curly hair problems.
We're also both dealing with something that we're going to be talking about today. So
That's
this
right.
is just going to be a fun episode. But before we get into that, we are going to share our weekly Bible verse, and mine is coming from Titus 3:4-7, which is, "But when the goodness and loving kindness of God, our Savior, appeared, he saved us, not because of works done by us in righteousness, but according to his own mercy, by the washing and regeneration and renewal of the Holy Spirit, whom he poured out on us richly through Jesus Christ our Savior, so that, being justified by his grace, we might become heirs according to the hope of eternal life."
Okay, so mine is one verse, and it is all that I can handle right now. It's like less than 15 words, and that is all that I can focus on. So mine is Isaiah 26:3. You will keep in perfect peace those whose minds are steadfast because they trust in you.
I
All
like
right.
it though. It's a
All
good
right.
one.
Yep. Yours
So
was too if I had
we
time to think about it. All right.
so we are continuing. I did believe this is our third episode on cognitive health, which if
Mhm.
you haven't listened to the first two episodes, highly recommend. We're kind of building on each one with information that we are disclosing, I guess, on what cognitive health is, which is what we covered in the first one, and then
Mhm.
some common reasons for cognitive health decline, such as alcohol use, glucose
Oh.
control, stress
Mm.
moderation, diet, things like that.
Mhm.
And we really ended on the focus of inflammation as being a huge driving force, which all of those things that I just listed are inflammatory agents in the body. So,
Mhm. Mhm.
today we are going to dive into more of that brain fog, dementia, and the cognitive decline of cognitive health.
All right. So today, oh my, today has been a challenge. Um so I just wanted to start, and I'm gonna touch on some things that people commonly have in their medicine cabinets, that they commonly have in their various medical pharma toolkits that they use for a lot of different conditions. And so we're going to talk about those in relation to the potential for dementia and even Alzheimer's. But to start, I just wanted to give uh, a little definition of brain fog and dementia, because people talk about brain fog all the time. I Lots of times I will have patients with a chief complaint of brain fog, and so you need to unpack that and find out what it means for each person. But if we combine what some of the commonalities that people mention, excuse me, I'm going to take a drink. And I'm back. Fuzzy thinking, lack of focus and clarity, not feeling sharp, feeling like you are thinking, responding, or recalling slowly. So when you just feel like you're just not on, right? Like your
Today?
processing speed. Yeah, today, pretty much today. Ashley and I have been complaining about this all day long to each other. So yeah, we've been kind of flighty today. Um, But yeah, that feeling of just like your processing speed is super slow. Like if you're old, then you remember defragging your computer, and I feel like I need to defrag. If anybody remembers what that is. So anywho, then we have dementia. So this is something different. This is like a clinical definition where you have a change or a worsening, and these two go together in the ability to think, work, remember, reason, engage in social interactions, and this in dementia we see a decline over time. So brain fog is very much like a sort of a transient kind of condition, so it kind of
Kind of
comes and
in the
goes.
moment, a day by
Yeah.
day type thing.
Exactly, exactly. So it could be related to like blood sugar, and then when you eat, right, then the brain fog goes away, or when you go outside, the brain fog goes away. But dementia is something much more organic, I'll say, and it declines, worsens over time. Also, integral to the definition of dementia is the fact that it interferes with daily living. So that's a big one. um we all have kind of our days where we feel really dumb, but that it doesn't interfere with our daily living. Like today I'm having a dumb day, but I can still ambulate, I can still get myself to the
She can
store.
still use big words.
You kill me. um Okay. Yeah. So anyway, I can still feed myself and do all of those things, and I also can still respond to the link that Ashley sent to get me into this chat room thing that we're using. So anyway, so that's kind of a definition of dementia. It is a worsening condition, and interferes with daily living. Now, so I want to kind of get into this connection between common drug agents and dementia, and I just wanted to point out something that was a little bit puzzling to me when I began the research on this low 40,000 years ago, it seems. I could not find a really clear connection between Alzheimer's and the drugs I'm about to tell you about. Now, that was a really weird, and now I'm talking direct connection, right? Like direct causal connection. Um, Not just correlation, but a causal connection. I can't find it. It's not in the literature, um, which was very surprising to me. However, there are causal links to dementia, and then dementia can progress to a frank Alzheimer's. So anyway, it's a bit of a uh, distinction without a difference, right? But I think that it is important to mention this because it kind of tells you where the state of the research is. It's these studies, like I've mentioned before, these studies are incredibly expensive, and so um,
And
there's not.
timely. I mean, they
Oh
time consuming.
yeah,
It's I mean, you're
yeah.
talking decades of following
Yeah,
somebody.
that's right. That's right. So anyway, let's see. Let's start with the big dogs, okay? So, um a class of drug, and I'm going to just put this in an umbrella of the benzodiazepines, okay? So these are drugs that I used to, when I taught pharmacology, I call them the Pams and Lambs. So this is like the Valium like drugs. So everybody knows what Valium is, everybody knows what Xanax is. Um, those are benzodiazepines, and they will sit on your central nervous system and just squash everything. Um, and I like to explain the activity of these really old drugs as the older drugs were very non-elegant solutions, right? It's like going after an ant with an elephant gun, right? So you would just shoot this giant bullet, and it would hit all kinds of stuff, right? The drugs we have today are much more like a sniper rifle, where we can target very specific uh, receptors in the body or proteins in the body. So the drugs that we have today have very specific affinities for certain kinds of receptors, and they're smart and they can distinguish between two different receptors that the old drugs can't. So when I'm talking benzodiazepines, these are super old. I think they were developed like in the 1950s. So going on 75 years of use. And so benzos, let's see, what are some other ones? Well, let's divide these into short acting and long acting. Okay, so people are pretty familiar with the short acting ones, and this is going to be drugs like Ativan or lorazepam and Xanax, or alprazolam. And so these actually are, and people probably also know that these are very habit forming. In fact, you become tolerant of these drugs in just a few days and dependent in just a few weeks. So, for our listeners that may not know the difference or the definitions for those, to become tolerant to a medication means that you need more and more of it to produce the same effect. All right. So, when we're talking about a sleep aid, most people use these for sleep aids or for anxiety now. And so they've been used for, oh my gosh, they've been used for so many things. They've been used for panic attacks. They've been used for seizure like activity. They've been used for, oh gosh, the list would go on and on. But primarily, what they're used for now is anxiety and sleep. And I would argue poorly used for anxiety and sleep. So they're really not supposed to be used for more than a few weeks unless if you can do it. I don't write for these drugs because they're terrible. You can't get people off of them, and they're horribly habit forming. So the dependency occurs after a few weeks, um, and that is hugely problematic because people don't get off of them after a few weeks. And here's the real problem: do they work? Yeah, they
Yeah.
work. They
Yeah.
work better than anything else. Anything. There is nothing that even comes close to working for anxiety like these drugs do. So, Andrea, why wouldn't we use them? It's because they're habit forming and you develop a tolerance so quickly. And because they are related, long term use is related to cognitive problems. Okay. So,
Same,
this
would that same be for opioids too, or is that going to be
Well,
different?
opioids are a completely different class. So that a completely different receptor. Opioids are going to bind a mu receptor, and these are going to bind a GABA receptor.
Oh.
Benzodiazepines, they when you think about GABA or gamma aminobutyric acid, GABA is a neurotransmitter that is very calming and sedating, but there's lots of different GABA receptors. Okay. There's like GABA alpha 1, GABA alpha 2, GABA alpha 3, and they all do different things. So that kind of leads us into, actually, I'm going to come back to that. So remember those different receptors. Benzos are kind of dumb drugs in the fact, in the because they can't distinguish between those GABA receptors. They bind them all, they affect them all. And so that's why we get, a change in cognition. That's why we get sleeplessness or sleepiness. That's why we get, memory functions. They cause lots and lots of problems. So let's see, long acting benzodiazepines are drugs like Valium and Klonopin. Okay. So uh those drugs not used much anymore, and I find this curious because when you're trying to get somebody off of benzodiazepines, it's much harder for them to wean off. And there should be, and please, please, please hear me, this is not medical advice, but please hear me, no cold turkey on these things. People can have extremely bad effects, um, on Oh, sorry, I'm going to put that away. People can have extremely poor outcomes when they're trying to get off of these drugs, especially cold turkey. It needs to be with a provider, and it needs to be like a slow taper. So it's easier to get off the long acting ones than it is the short acting ones. So sometimes people will even switch patients onto a long acting one, and then well, darn it, it's my work girls. They are just texting and texting. Here, all right, I'm gonna throw them on the floor.
Turn your
Um,
turn your
I don't know how to do that, Ashley. Yeah, I
okay.
know you're trying to tell me to do some shenanigans that I don't know how to do. Um,
Okay.
so yeah, so the benzos, long acting, better than short acting, better to for people to get off of. Now, that brings us to the newer class of drug called they're sometimes referred to as the Z drugs. They're also referred to as like benzo like sedative hypnotics. The reason that these are the reason that they are lumped in with benzodiazepines, they're not quite the same, but they are similar enough that if somebody overdoses, they will reverse with the antidote, if you will, is the same as it is with a benzodiazepine. So I'm talking about drugs, and the reason they're called the Z drugs is because most of them either start with Z or have a Z in them. So Zolpidem, everybody knows this one, it's Ambien. Zopiclone, Zaloplan, S-Zopiclone. This is like Lunesta, Sonata, and I can't remember what the other one is. But anyway, these are all drugs used specifically for sleep. Here's the reason why, because they can tell the difference between the GABA receptors, right? And they will only bind to that GABA alpha 1 receptor, which is responsible for, state of consciousness. So they will cause you to sleep.
That's
So
crazy.
they're smart drugs, if you will. So but these drugs now, the if you look at the package insert, you look at the drug information, it says don't use these for any longer than 6 weeks. Like that is the absolute max that anybody should be on these things. People are using these for years,
Yeah.
years, decades. It's crazy. And studies showed that in an over 65 population, showed that balance and cognitive impairment occur after 1 to 3 days of use
Oh
during
wow.
waking hours. All right. So upon awakening, you've got balance and cognitive impairment. Now,
Which you don't
eh,
need at that age
right?
anyways.
Right. Okay. So think about this. So even if we don't have a smoking gun evidence that it is related to Alzheimer's, even if we don't have that direct correlation, look at the level of disability that these things can cause when you upset balance and you have cognitive impairment, right? Falls.
So it's like, okay, well, how
Mm-hmm.
can it not be related or a causation?
Exactly.
You know,
Yes,
like,
and I think it's just nuanced in the literature. Like I'm not sure. I honestly don't think that a good quality study has really even been done to determine if they're causative.
yeah,
But if you're impairing balance and cognition upon awakening in an over 65 population, well, one of their biggest enemies is falling,
yeah.
right? The level of disability that occurs after a fall is just mind blowing.
So wouldn't the liability alone pull
Well,
these
one would think. Are
drugs?
you kidding me?
You
Are
know?
you kidding me? Yeah, no, they're so insulated. Um, no, it's buyer beware,
Yeah,
buyer beware. There's side effects, they're easily found. Um, but yeah, nobody seems to pay attention. So another study that I looked at found changes in the mental status, um, i- including disorientation to time and place. Like, okay, if you wake up, and these were in Ambien patients, if you wake up and you don't know where you are and what year it is, that's a significant disorientation. And so, yeah, it
it's like a
changes
date
mental
rape drug.
status. Yeah, absolutely. Yeah, like a Rohypnol. Uh-huh. And they're probably they're probably chemically related. I'm trying to think Rohypnol. Yeah, that is a hypnotic. But anyway, so then there was a final retrospective study that found significant risk. Now, listen to this. When they looked at people, there was a peak in the data at 28 milligrams per year. Okay, the dose of these things, the nightly dose, is anywhere between 5 milligram. Now this is Ambien, so we're talking Ambien here. It's in the Ambien analogs, all those different Z drugs that I mentioned. It's going to be very similar. Um, but in Ambien, the nightly dose is between 5 and about 12 milligrams a night.
And this
S
study was 28
Yeah,
milligrams per
per
year.
year. You
So
could
you're
get there in
getting
3
that within a
nights.
yeah, I was gonna say
Yeah.
3 days.
Yeah, that's right. You get there in 3 nights. So they had a peak in the data there, and then they compared that to those who had greater than 180 milligrams. And I mean, the study acted like, oh, greater than 180 milligrams, that's like a heavy user. Okay, so if you're on 10 milligrams a night, that's not even the max dose, by the
It's
way. But if
18
you're on 10
days.
milligrams a night, it's 18 nights. 18 nights, and you are in heavy
Considered a heavy
user.
user.
Yeah, and you have significant risk for dementia.
Wow.
So yeah, this is problematic. This is really problematic.
And it's not being discussed once again.
No, it isn't. No, it isn't. And patients are just allowed to just um and yeah, providers really need to have this conversation. Um and try and get these people off of stuff. And it's not popular. I got to tell you, it's not a popular message. Like when I say things like, oh, gosh, I don't really write for that drug, or, oh, I really try to avoid using that drug, or let's try to get you off of this. It's not a popular conversation, I'll tell you. But the data is on the side of getting off of it, right?
Yeah.
So,
Wow.
so there are also some accepted short-term side effects that I just wanted to mention here that we know about. I mean, this is like, oh yeah, everybody knows that. Well, okay, slurred speech, yeah, transient amnesia, and this is in the waking hours. So when you wake up after even taking appropriately, this is a side effect, right? So slurred speech, transient amnesia, and then impaired motor and cognition function. So again, we're just setting people up for falls because when do you start when do you start getting to the point where you're having sleeping issues? Well, for women, a lot of times, and I promise we're going to do a hormone. We're going to do a hormone set of podcasts. But for women who are entering perimenopause, that weird perimenopausal state, and menopause thereafter, yeah, sleep is a huge deal. It's a huge deal. And so instead of checking hormones and dealing with the root cause, a lot of times people would just get put on sleep meds and then they just
Yep.
get left there. It's like they just get forgotten about. And, the patient's not complaining because they're sleeping. Now, it's not a
Right?
quality sleep, but they're sleeping. And so they might be getting up in the middle of the night and making a sandwich or, turning the oven on, but okay, they're sleeping. Yeah, there's lots of weird side effects with these things too.
Mm.
So yeah, it's problematic. Those drugs are horribly problematic. And again, Here's the thing. Patients will say, "Okay, but nothing works as well as this." You're
Mhm.
right.
Right.
You're right. I acknowledge that. You're right.
Yep.
But we need to acknowledge that and then get past it.
Mhm.
Because you know what? I bet people would get really great sleep on cyanide too. But that doesn't necessarily mean that that is the most therapeutic option for somebody, right?
Oh my gosh.
So, yeah,
Do you
it's or
think
propofol.
providers that are
Yeah.
prescribing these, do you feel like they truly understand this level of
I think so. This is not rocket science. This is something that it's kind of the dirty little secret, right? Like it's kind of like PPIs, which is like proton pump inhibitors,
Oh
like
yeah. Mhm.
like Protonics, like
Like
Prilosec, like oh sorry, that's an
heartburn
H2.
stuff.
Yeah, it's the big dog heartburn medications.
Uh-huh.
Um those are only supposed to be used for a matter of weeks.
Yeah.
But people are on them for years and years, and we know that it
Pop once a
causes.
day and I can eat
Yeah,
whatever I want.
yeah, absolutely. And you can sleep, right? You can sleep through the heartburn now. So we know that those cause osteoporosis. We know that those cause horrible problems over time. But you can't digest your food. You can't absorb nutrition. They're awful. They're awful. But we just continue to use them, and this is kind of in the same line of thinking that, well, it works. Um,
Yep.
and patients don't want to go off of them. So it's a shared responsibility here, right? I absolutely don't lay this all at the feet of the providers. Like, patients don't want to go off these things,
Well,
and
that's what I was going to
so
say is like the reason why
yeah.
we're discussing these things is one, we want you to be more informed on
Hmm.
what is actually going on in your body and what it's actually doing as a whole. Because I think it was this last week's episode, we were just talking about how the gut, the brain, everything connects and it talks to each other.
Yeah.
So just because you take one thing for one problem does not necessarily
Hmm.
mean it's not affecting other parts of your body. It most certainly
Yeah.
is.
Yeah, and there are wide ranging effects from these things. you
And
know
with everything, like you should have
uh-huh.
informed consent. Like if the
Right.
side effects and the long-term effects to your body is worth it for
Hmm.
you, then
Hmm.
at least you know.
Right.
Whereas
Right.
instead of just blindly following
A
and
recommendation.
taking, yeah,
Or how about blindly following a feeling, right? Because
true.
again, we come back to, these drugs work,
Yep.
right?
Hmm.
Nothing works like them for anxiety.
Exactly. And
However,
and some people are to their wits end and
right,
they're like, I will just
right,
do whatever I can to feel normal again.
right. Yeah. But it's a short-lived, right? Because of the
Hmm.
tolerance and dependence that builds. So yeah, I get it. It's a problem. It's a problem. I don't have any great solutions except to try to educate people and say, hey, listen, you don't have to stop if you don't start.
Exactly. Yeah.
Okay, next class of drugs. These are these are going to seem much more benign. Um however, there is still a link. I am so sorry. I have like a frog in my throat. Hang on, I'm gonna get a drink here. Mm. Okay, so these are the drugs that everybody has in their medicine cabinets, in one form or another. So again, a lot of these are super old drugs, and so now we use them for all kinds of things, right? They're all central nervous system depressants in one way or another. They all generally cause some. So I'll go through all of the effects. So they generally cause sleepiness, they generally cause decreased cognition, they generally are antihistamine, they generally are anticholinergic, they're anti-vertigo or dizzy, they're anti-nausea, and sometimes they're even antidepressant agents. So all of these fall under this broad umbrella of anticholinergics. And when I talk about that, I'm talking about the drugs that block acetylcholine. So acetylcholine is a major neurotransmitter. There are cholinergic receptors all over the body for all manner of things, and primarily, lots and lots in the brain. These drugs readily cross the blood-brain barrier. They have lots of activity in the brain, and so that's why the first class of anticholinergics, um, uh, uh, I'm going to talk about the antihistamine first, okay? So, antihistamines. So, when you think anticholinergic, and this is taught to you in, pharmacy, nursing, medicine, you're taught that anticholinergic. Okay, if a drug has anticholinergic effects, then you are going to experience side effects of no C, no pee, no spit, no, you fill in the blank. Okay. So it inhibits secretions. All right. So it's going to literally dry you up in all kinds of ways. Okay. So urine production, tear production, etc. So for an antihistamine, that's a pretty good deal, right? Um, but I'm talking drugs like Benadryl, like diphenhydramine, right? Some of you know Unisom. That's dimenhydrinate. That's a old sleep drug, very similar to Benadryl. They're chemical cousins. Then we've got like brompheniramine. This was a Dimetap, I think, was an old cold formulation. Again, another antihistamine. Dimenhydrinate. This was Dramamine. The
Oh, yeah.
old nausea, right? Or
Mhm.
seasickness. Yeah.
Yep.
So that it's a super old antihistamine. So they all have those effects. Then we've got the prescription ones, and there are several of these, but kind of the class typical agent would be like a hydroxyzine. And interestingly, we are now using hydroxyzine for sleep and also for anxiety. Now, guess why we're using it for anxiety? Because it's not a benzo. So we can't be starting people on these benzos. And we're finally getting it through our collective medical brains that you can't start people on these benzos because you never get them off, because nothing works quite like them. So you start them on something like an antihistamine. However, they seem very benign, right? Well, it makes me sleepy, but it helps with my anxiety. And, um, it's a chemical cousin of Benadryl. How dangerous could that be? Well, they are linked to mild cognitive impairment with later on in life, and then which can become full blown dementia. So again, guys, things like Benadryl, things like Unisom, things like these drugs that you can buy over the counter that are, sleep aids or antihistamine, if they cross the blood brain barrier and make you sleepy, then they are related to cognitive impairment. That's just across the board. Then we've got anti-vertigo medications. So perhaps some of you remember a meclizine. This was like Antivert, or it also went by, I think, an over-the-counter name, Bonine, but that was used for like a motion sickness or vertigo, feel nauseous. There are also other older anti-nausea meds that actually we use them for psych stuff now. So promethazine or Phenergan. Phenergan used to be a pretty stereotypical anti-nausea medication, but now we use it in headache cocktails. We use it in for psych exacerbations when we're trying to really calm down a patient that's having like a break. We can use prochlorperazine, which is the counterpart anti-nausea med. So these meds, again, they're super old, so they do a million things, right? They've got a million targets. Also, another old one, droperidol. Um, it has kind of come back into favor. It was in the penalty box for a little while, but now he's back, droperidol. And so, um, but these are the old anti-nausea meds. Okay, these are not the newer generation. So probably most of you have heard of Zofran, right,
Yep.
or ondansetron. Okay, so that's the newer generation of anti-nausea meds, and you don't get that heavy sedation that you get with the old drugs. So you don't get all that anticholinergic effect. And then finally, there is a class of anticholinergic medications that was used as an antidepressant class called the tricyclic antidepressants, and these are drugs like doxepin or Sinequan, or amitriptyline, also went by Elavil. Amitriptyline, we use both of these for sleep. Again, why on earth would we be using these instead of benzos? Because they're not benzos. that's
They're not
that's
as
literally why.
effective.
Yes, that's literally why. Is because they're not benzos, and you don't have to get people off of benzo. We also will use a miscellaneous antidepressant that has some anticholinergic activity called trazodone. We use that for sleep all the time,
Yeah.
and it actually works pretty well. It works pretty good. So, yeah, trazodone's a good one. But again, we don't want to use this all the time.
Yeah.
because of the cognitive impairment that will result later on.
So trazodone
Yes,
crosses that
that's
blood-brain barrier
mhm.
too? Okay.
Absolutely. Yeah, and in fact it's a miscellaneous antidepressant. There really isn't another drug in a class like it. It was
Mhm.
kind of a one shot deal in its class. Um and so that's kind of what we're looking at here when we talk about drugs related to dementia. And you can see that these are very commonly used medications.
Yeah, I was gonna
They are
say.
right. Yeah, like how many of these do you have in your cabinet? I've got probably four of these
Yeah.
in my cabinets right now, and I'm not a drug taker. Like I don't take Benadryl, I don't take hardly any of these things, but I have them all.
Yeah.
um so yeah, they're ubiquitous, everybody's got them. But just you don't want to fall into those habits of using them all the time because they're dangerous.
Yeah.
Okay, so the next thing that I wanted to go into, I'm gonna head back to drugs, but it'll be like the kind of capital D winky winky drugs that we'll get into later on. But the next thing that I just wanted to mention this, and I know we brought it up in another episode, I believe, but I just wanted to mention because I did try to do a deep dive into diet, and some dietary habits
Yeah.
related to dementia, and there have been some studies, believe it or not, there have been some studies. However, when they talk about those studies, so I found some meta analyses, which is like a really, uh, it's a high level of evidence. A meta analysis is a good evidentiary piece. However, whenever they mention these studies, in the meta analysis, they would always put ultra processed foods. So they looked at processed foods in relation to dementia. And whenever they would say ultra processed foods, they put in parentheses, example, processed meats. And that was the only example they ever gave in the whole paper, like any of the papers that I was looking at. I'm thinking, okay, yeah, like yes, there are some ultra processed meats and they're full of nitrates and nitrites and sulfites, and like they're full of chemicals, and I get that. But there are whole swaths of ultra processed foods like
Mm.
Cheetos and chips and crackers
Hey
and
now. Hey now.
I know. I know, but like how can you just like
Yeah.
point a finger at processed meats and then not mention any of the other monstrosities like donuts? What's a donut, right? What is a donut? What's a Twinkie that's got a
Yeah.
shelf life like a cockroach? I mean, they will survive a nuclear blast. So I find I find it just a little suspect that,
Yeah.
you know, it's always pointing the finger at any kind of meat that they can.
Well,
So
I
that's a little
mean,
off-putting.
something to look at is who's funding that study.
Well, yeah, and that would have been, yeah, absolutely, just to see who's putting the money up for that. So
Hmm.
anyway, but they definitely found a link between ultra what they consider to be ultra processed foods and dementia. Okay,
Which,
so
if you listen to our last episode, we talked about I think that's
yeah,
when you were mentioning the diet
mm-hmm,
piece a little bit, was that food has inflammatory agents, and so trying to
yep,
stay away from those like seed oils and um,
yes,
well, ultra processed foods, which is basically seed
mm-hmm.
oils.
Yeah, absolutely. And
Like,
so and things that have a shelf life of like years and years and years without refrigeration, without canning, without anything like that, it's like you should be suspect of that. You
yeah,
should definitely be suspect of something that doesn't break down.
yeah. I mean, we
That's
all
real
laugh that
weird,
the McDonald's burger lasts what 40
right?
some years, but
Okay,
really, it's
well,
like,
Yeah. Okay, so McDonald's, that's kind of low-hanging fruit. How about every single ice cream that you have access to at the grocery store? Put that out on the counter and see what happens. Like put that next to a really good quality ice cream that will
Uh-huh.
actually melt. See what
Yeah.
happens to this grocery store ultra processed ice cream or
Yeah.
ice cream food or Velveeta or what
Oh my
what
gosh, yeah.
have you. There's
Mhm.
so much trash out there, but yeah, let's impugn ultra processed meat alone. So
Right,
yeah,
exactly.
ridiculous.
We might be a
Um,
little bitter.
I am bitter. Yes, I'm very frustrated about that. I feel like, yeah, I feel like there's enough that we can point a finger at that we don't have to just be one
Well,
trick
it's just
ponies.
sending the wrong fear factor
Mm-hmm.
for things that
Exactly.
potentially aren't necessarily the first on the list for danger.
Yes, precisely,
So,
precisely. Okay, so the next thing I'll say, lifestyle, being
mhm,
sedentary, linked to
yeah,
dementia. Sleep. There is okay, you guys. This is super interesting. But there is data. There is a U-shaped curve with sleep. Too little or too much.
interesting.
All increase excessive time in bed, excessive time sleeping increases your risk of dementia. Um,
What's
so,
considered excessive,
well, that's a really
and
good
what's
question.
considered and what's
You know,
considered too little, I
so
guess.
too little would be considered less than 6 hours.
Okay.
And they looked at people in their 50s and 60s and found and that's not that old, right? But they found a 30% increased risk for dementia.
I mean, I know several older individuals that they'll joke like, "Oh, yep, I sleep maybe 4 hours a night."
Ah, yeah.
You
Well,
know,
that's problematic. That is definitely problematic. Also, the next thing I wanted to mention is lack of learning.
oh,
So, when you get too sedentary with your brain, if you don't exercise those connections, if you don't continue to learn, that is also linked to poor cognitive outcomes.
that's why like wasn't Sudoku like linked to helping.
I think so.
I
Yeah,
think there
I
was like
I
a
think
study,
so.
maybe
Those kinds
potentially. I
of
don't know.
cognitive puzzles. Yeah.
Yeah.
Yeah, I think so. Also
I mean,
human
even putting,
interaction. Mhm.
yeah, I mean, even putting together a puzzle, like, uh,
Right.
I mean, you're having to look at
Yeah.
shapes
Yeah,
and you're
absolutely.
you're solving a problem basically.
Mhm.
So,
Yeah.
yeah.
Okay, so then the last thing, and then we can let people go, is the winky winky drugs. So talking about cannabinoids, like THC, marijuana. I always ask about this with my intakes because a lot of people are using these. And there's some interesting data out there. THC is probably so it is in a roundabout way contributory to Alzheimer's disease, but probably via vascular dementia. So if you don't recall the difference, go back to the first one and listen to the difference between vascular dementia and other types of dementia. But cannabinoids reduce blood flow significantly to the hippocampus, and that is the learning and memory center. So they can cause long lasting declines in memory, and also an inability to learn over
That's
time.
interesting.
So, yeah, you don't want to reduce vascular blood flow to the brain. That's bad news. And then alcohol, which is quickly becoming the elephant in the room. Um, Hang on just a second. So alcohol, let's see. I looked at several things regarding alcohol, and what I found most enlightening. Now we know that alcohol causes all kinds of problems. It's very neuroinflammatory. It's very gastroinflammatory. It's just inflammatory,
Hmm.
um, but it causes inflammation in the brain, and the uh, the study that I looked at, which again was a really nice meta analysis of all the data that they could find, um, they they designated heavy alcohol use as 14 or more drinks per week.
Which is
So
2 drinks a night.
that's 2 drinks a night, and there's an awful lot of people doing this.
Mhm.
And that is absolutely tied to dementia
Wow.
and reduced brain volume. So, like, you're literally losing brain volume with the alcohol, and alcohol very readily crosses the blood-brain barrier, as we know because we get effects, right?
Right,
Like, you get
exactly.
effects from alcohol, yeah. And so, yeah, alcohol use, yeah, you guys, it's, again, informed consent. I don't have anything against it, it's just informed consent. And it's kind of become the new Xanax, right? It's kind of become the new vitamin V. Like in the 70s, everybody was on Valium. It was this new drug that, that all the mommies would take, all the stressed out mommies would take because it was very in vogue. And now it's almost like alcohol has kind of replaced that.
Mm.
And finally we're starting to get some information out there about the long-term effects of alcohol use, and especially in women. Like, our livers are just smaller, they're smaller, there really isn't anything good that comes from alcohol use. So just be mindful, be informed.
Which is funny, so I don't know if you saw this, but the DEA has actually reclassified marijuana, as a less dangerous drug. I don't
what do
know if you
you
saw that.
what do you mean?
So, they've
Did
reclassified marijuana as a less dangerous Schedule 3. It's a Schedule
Oh,
3
yeah,
and a
yeah, yeah,
Schedule 1.
yeah. It used to be a Schedule 1. So DEA schedules, Schedule 2s are pretty much confined to opioids. Um, there are some other drugs there too, but pretty much opioids as a class. Now, Schedule 3, so Schedule 1 was relegated to anything that was considered to not have a medicinal use.
Mm,
And so that's why there's been this huge, like, back and forth between state agencies and federal agencies, right? Because when you look at drug laws, you're supposed to follow the stricter of the two laws, right? So if the state law flies in the face of the federal law, the law that supersedes is the more strict of the two. So if the state is more stringent than the federal, then you follow the state. If the federal is more stringent than the state, then you follow the federal.
okay.
Except in the case of marijuana, it's been a huge fight, right? Because technically, if people have marijuana, they can they can be picked up like they have heroin on them, right? It's
Yeah.
a Schedule 1 drug. So they
Mhm.
really needed to make this happen because states are legalizing it for various, and there's various legislation that states have passed. Like, some states, it's just a free for all and anybody can get it anytime, anywhere. And then there's other states that are like, well, let's just do medical cards for marijuana, and you can get it for medical uses. So anyway, there's all of that going on, but you're still, even if you're doing it for medical use, you're still accessing a Schedule 1 drug.
Yeah.
So they really needed to do this. And it certainly isn't in the same class as like an opiate. And so they
Yeah.
really only had one choice, which is to call it a Schedule 3. Now,
Uh,
that there are all kinds of differences between Schedule 2 and Schedule 3. So, for instance, if you have a prescription for a Schedule 2, you have to get a new prescription every single time for that. For
okay.
Schedule 3, 4, or 5, you can put refills on it, you can call it in. Like, there's uh, more leeway that you get, and it's not considered as addictive. So anyway, yeah, I'm not surprised that needed to happen. And regardless of how you feel about the use of CBD or THC, is the neuroactive,
Right.
um it's still, people are really confused about that, and rightfully so.
Mhm.
The feds and the state agencies can't work their stuff out either. So yeah, that needed to happen while we're still having this marijuana conversation about where people are going to land on this.
Mhm. Now, with marijuana, CBD, THC use,
Mhm.
is the cognitive piece only when ingested, or is topical use? Because I know a lot of people use it
Mm,
as a topical agent.
yeah, there is some absorption. There is, so again, CBD doesn't seem to have that neuroactive component to it.
Yeah, that's
Um,
THC.
yeah, it's the THC that does, but there is some absorption. My understanding, again, which is limited, but my understanding is that you do get some of the psychoactive compounds that can absorb across the skin.
Okay.
Yeah.
So, yeah. All right. Well, this was very
Mm,
interesting
yeah,
and enlightening. I mean, I think people need to realize that, just because it's, what drugs that are so
mm,
common and, like you said,
mhm.
over the counter that you can just
Yeah.
go to Walgreens and pick up, like,
Mhm.
there's effects to the body that have long-term effects. So,
Right. Well, and
um,
I also feel like it's important because, I mean, as providers, we write for a lot of these drugs too.
yeah.
And so
So if
you
you were going to somebody like Andrea and
mhm.
she's like, I really am hesitant to write this for you, there's a reason behind it, and it's not just because she's a big grumpy old, practitioner. Like she
Get off my lawn. No, you can't have it. No, there is a reason for it. And again, it just all comes down to you don't have to stop if you don't start. And
hmm
these things, they are highly addictive. And and beyond that, like beyond even the addiction, it's the dependence that you build up. Like you
hmm
can't sleep without them, and I
Right.
know they work. I know they work. The fact that they work is not in question. They
Right.
unquestionably work. Like they work.
Yeah.
But it's, it's too much. It's
Yeah.
too much. The downside is just too great.
Well,
Of
thank you so much for looking into all this and researching it and
course.
providing it in a way that we can easily understand. And if you have questions about any of this, please definitely shoot us an email or find us on
Yeah.
Instagram. Our contact information is always in the show notes. And as always, if you have found this episode or any of the other episodes that you've listened to, informative and educational, the biggest compliment that you can give us is sharing it with your friends and family, but also giving us that wonderful 5-star review on whatever platform that you are listening on. And so we
Sharing
will.
is caring.
Sharing is caring. We are going to continue this once again. We're probably looking at maybe six,
I think
five,
5. I think we
six,
can get
five.
it at 5. I
Okay,
think. I think.
five
Yeah.
episodes. If not, we'll wrap it up in six. But
Yeah, we'll
yeah, this
see.
this is such a great topic, and it's definitely something that needs to be talked about because it's it is
It's
real life. Like
everything. Yeah, it's
it's
your
literally
brain.
everything. So if you don't have the brain, you don't have much. So
That's right.
so
That's
we will
right.
catch you on the next episode as we continue this discussion on cognitive health, and we will see you then.
Bye. The content provided in the AA podcast is intended for informational and educational purposes only. The podcast is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. The information and opinions expressed in this podcast are solely those of the individuals involved and do not constitute medical advice.